Once again, welcome to this webinar. My name is Chelsea Lee, and I'll be your moderator today. Today, our speaker is going to discuss how to manage CO2 to improve outcomes in patients with chronic respiratory failure. As we begin, keep in mind that you can ask a question at any point during the webinar. Just go ahead and click on the Q&A button at the bottom of your screen and type in your question. We will answer those as time allows at the end of the webinar. If you have any technical difficulties, you can go ahead and type that into the chat box. This course is accredited by the ARC, the AAST, and the California Board of Nursing for 1 contact hour. To receive your certificate, you can just fill out the evaluation form that will pop up at the end of the webinar. If you happen to miss the link the first time, you will also receive a link in your follow-up email. Just complete the form and include your AARC, your AAST, or your nurse license number if you have one. You will receive your certificate by mail, but just be sure to complete the evaluation to receive your certificate. So now I'm happy to introduce our speaker for today, Dr. Philip Choi. Dr. Choi is a clinical associate professor of medicine and neurology at NYU Langone Health. He is the director of the Chronic Respiratory Failure and Home Ventilation Program, as well as the co-director of the Andre Cournand Cardiopulmonary Physiology Lab at Bellevue Hospital. He received his MD from Mount Sinai School of Medicine, completed his residency in internal medicine at Brown University, and his fellowship in pulmonary and critical care medicine at Duke University. After completing his training, he remained on faculty at Duke, where he worked in the ALS Center of Excellence. From there, he moved to the University of Michigan to become director of the Assisted Ventilation Clinic, a multidisciplinary program caring for patients on home ventilation. So Dr. Choi, thank you so much for joining us, and I will turn it over to you.
Great. Thank you so much, Chelsea, for the invitation to be here. Just let me go ahead and share my slides. Okay. Does that look good, Chelsea?
Looks good. Thank you.
Okay. Great. So thank you, everyone, for being here. It's great to see everyone virtually. And as Chelsea mentioned, I am now at NYU Langone. I just moved here a few weeks ago. So really building up this program in chronic respiratory failure and home ventilation as I start here. Just started my first clinic last week. And so I'm going to be talking to you a lot about some of the work that we did at Michigan when I was there and the ways that we've used CO2 monitoring to improve patient care and improve outcomes. And so I just have one disclosure, and that's that I'm a clinical advisor for the vent company Breas. And so I like to start out with a case. This is a case of a 56-year-old male with COPD, morbid obesity with a BMI of 50, heart failure with preserved EF, and he presents with acute on chronic respiratory failure. His initial blood gas shows an acute on chronic respiratory acidosis. He is admitted to the ICU. After 2 days on non-invasive ventilation, his ABG is 7.38, PCO2 of 78, PaO2 of 80. And then at that point, the patient is transferred to the floor and the medicine team takes over care. So for any of you who work in the inpatient setting, I'm sure that you can imagine that this is a very realistic case. This probably happens frequently throughout the week of patients who have elevated PCO2, a normal pH. And so the big question is, what do you do in that setting? I know historically I've kind of had this mantra, or there's been this mantra in medicine that as long as the pH is normal, that PCO2 doesn't matter. This is just technically where they live. But as I started to think about this type of patient and started to be more in this field of non-invasive ventilation, the question is, what do you do in this situation? Do you need to get a sleep study? Do you start non-invasive ventilation, or do you just let them be because technically, quote unquote, this is where they live? And so as I go through this talk, I really want people to understand that chronic hypercapnic respiratory failure is a problem with very high mortality. I'm going to review the data regarding non-invasive ventilation as a treatment for chronic respiratory failure, understand the importance of CO2 reduction to improve outcomes, and then also think about strategies to monitor chronic mechanical ventilation. And so this is just a slide. I'm sure everyone who has gone through some sort of pathophysiology course, whether it's in med school, nursing school, respiratory therapy school, we've really learned that, acid-base balance is a tightly regulated system between the lungs and the kidneys. And when we think about problems that are truly alveolar ventilation, we're really talking about the inability for the lungs or the respiratory pump to maintain adequate ventilation. And this leads to problems with increasing carbon dioxide over time. So I'm going to really be focusing on problems of alveolar ventilation, not necessarily acid-base issues primary to the kidneys. And so when we think about the causes of alveolar ventilation issues or alveolar hypoventilation, it's really important to understand potential etiologies because these, one, it's just important to understand that not every disease is created equal, and that, there are various different etiologies that patients have in terms of why they might hypoventilate. But it also has effects in terms of how you actually undergo mechanical ventilation and also some of the insurance criteria for how we start non-invasive ventilation. So COPD and airways diseases, I think that's a pretty known common cause. You have your hypercapnic COPD patients in the hospital who end up getting started on some sort of mechanical ventilation. I deal with a lot of neuromuscular disorders, including rapidly progressive neuromuscular disorders like ALS. One of the conditions that I never really thought about too much as I was going through my training were just restrictive thoracic cage disorders. So this can be from kyphoscoliosis. So if you have someone with really bad kyphoscoliosis, that can actually lead to pretty severe hypercapnia over time. Pulmonary edema can contribute. Upper airway obstruction can as well. So if someone has really bad OSA, they can develop periods of hypercapnia that can lead to daytime hypercapnia as well. And then always think about the idea of decreases in central respiratory drive. So it may be something that people are born with. There are conditions where people just cannot breathe because something central. It can be acquired, like in a stroke or something like that. But also think about medications, because a lot of these patients who are chronically ill actually are on a lot of sedating medications that can decrease central respiratory drive. And so in terms of chronic hypercapnia, there's actually quite a bit of data. Let me just make sure. I think I skipped over one slide. So when it comes to acute hypercapnia, there's actually quite a bit of data that shows that acute hypercapnia is bad. So this usually is associated with acidosis. So in acute exacerbations of COPD, PaCO2 is an independent risk factor for death. And this has been shown in multiple different studies. It's also true in community-acquired pneumonia. They found that there's a higher risk of death and 30-day readmission for patients with higher PaCO2. And then also in acute heart failure, there's higher rates of intubation with elevated PaCO2. So in acute hypercapnia, we know this is bad if they're acidotic. And so we're pretty readily inclined to treat those patients with non-invasive ventilation to try to return them to a normal pH. But what about chronic hypercapnia? So there is some data out there that shows that in stable COPD with chronic hypoxia, that's in oxygen-dependent COPD, that PaCO2 is an independent prognostic factor with a U-shaped association with mortality. So if the PaCO2 is high in those patients with chronic hypoxemia, that patients die more. And then also if the PaCO2 is low as well. So that normal range is really important. If you're high, there's probably issues with the CO2 actually causing some sort of mortality, but also if it's low, likely it probably represents some element of respiratory distress and hyperventilation at that time. And studies have also shown that median survival is longer in patients with normal capnia than those with hypercapnia. So there is some data, but not quite as robust as acute respiratory failure. But we know that all our patients don't fit into one box. So even though there are studies in COPD, we know that a lot of our patients actually have multifactorial hypercapnia. So they have various different reasons for alveolar hypoventilation, including maybe some heart failure. Our patients are increasingly obese. They may have some degree of lung disease. And again, medications that may decrease central drive. And so there may be potential multifactorial reasons, and there's not necessarily a lot of data on these types of patients that we see on a regular basis in the ICU. And so based on the fact that, not all our patients fit into this one little box, I was really interested in understanding what happens to patients, irrespective of what their underlying reason for hypoventilation is, but what happens to these patients when their CO2 is chronically elevated. And so along with one of my mentees at the University of Michigan, Matthew Wilson, and one of my colleagues, Wasim Labaki, we wanted to answer this question. So this paper was published several years ago in the Annals of the American Thoracic Society, looking at mortality and healthcare use of patients with compensated hypercapnia. And so what we did was we did a very simple electronic medical record query where we looked at all patients who were admitted to the University of Michigan Medical Center between January 1st of 2018 and December 31st of 2018. So we included any patients who were of adult age, who had an admission during that 2018 year. And we were looking at patients with an ABG pH of 7.35 to 7.45, so normal pH, and a PCO2 of greater than or equal to 50. So technically above 45 is abnormal, but we really wanted to focus on those patients who were a little bit sicker. So compensated hypercapnia, but a little bit more elevated than what we would consider the upper limit of normal. We excluded patients who were less than 18 years of age. Any patients who had only venous blood gas data, we did not include. We did not include patients who were admitted to psych or PM&R hospitals or outside hospital admissions. And what we found were 491 unique patients in the cohort. And so we were looking at demographics like age and sex. We looked at whether they had comorbid conditions that might contribute to alveolar hypoventilation, including congestive heart failure, COPD, neuromuscular disease, OSA. And we also calculated their Charlson Comorbidity Index, which is a composite score that looks at 10-year post-hospitalization mortality. Body mass index, we looked at their ABG data, finding an ABG that fit the criteria with a normal pH and an elevated PCO2. We got their bicarbonate data from a BMP or CMP on the same day as the ABG. We looked at whether they had any spirometry data and whether or not they were using outpatient NIV, although we did not evaluate compliance. And so these are the baseline characteristics of our cohort. You can see that there's an average age of 60, a little bit more male and female, predominantly white, which is just the nature of being in Ann Arbor. Body mass index, slightly overweight, and then just distributions of comorbid conditions. And we also broke down into various levels of PCO2. And this is some of the other data that we found. So there was an average PCO2 of 58.8 with an average serum bicarb of 33.3. As you note, most of these patients, or about half of the patients who had spirometry, did have obstruction based on their FEV1 to FVC ratio. And then if you look at the bottom, the number of patients who were prescribed outpatient non-invasive ventilation was less than 25%, but that you can see that with increasing PCO2 levels, that a little bit more of the population was actually being prescribed non-invasive ventilation. So again, we did not account for any adherence data, but at least it seems like once people were getting to the extremes of disease, that it was being recognized that non-invasive ventilation might help. And so what we found were that there were 1,141 inpatient admissions, with 44% of the patients having 2 or more admissions during a 1-year period. Over the 12-month time period, beginning with the initial ABG date, the median number of cumulative hospital and ICU days were 21 and 7, and this was only at the University of Michigan, so obviously high utilizers of the healthcare system. And then during these hospitalizations, 298 patients required invasive mechanical ventilation during their hospitalization. And as I mentioned, only about a quarter were prescribed outpatient NIV therapy. And these are our Kaplan-Meier survival curves looking at various levels of PCO2. So you can see in the blue at the very top, those are patients with PCO2s of 50 to 54.9. The red in the middle is a PCO2 of 55 to 64.9. And the green at the bottom is a PCO2 of greater than 65. And so as you can see in a very clear delineation, the mortality over the follow-up period was related to the levels of PCO2. So from this data, you can at least determine that based on elevated PCO2s, that your mortality increases with the higher the PCO2 levels. And we found in a multivariable Cox regression model that PCO2 was independently a cause for or related to all-cause mortality. And this was after we adjusted for age, sex, BMI, and Charlson Comorbidity Index. And so you can see that there's an increasing hazard ratio with every 5 millimeters of mercury increase in PCO2 from baseline. And this showed, this analysis looked at the interaction between BMI and elevations in PCO2. So this isn't saying that BMI is independently a risk factor for death, but that as BMI increases, with more elevations in your PCO2, you're more at risk of death. And so based on this study, we really wanted to dive into, or based on our results, we really wanted to dive into why this might be the case. And so we found this study that was done out of Northwestern University looking at a potential mechanism in humans. And so this was a mouse study that looked at host defenses based on hypercapnia. And what they did was they exposed mice to different levels of, or higher levels of CO2 for different amounts of time. And what they did was they basically exposed mice to 10% CO2 for various amounts of time. So as time goes on, the pH starts to normalize, which is really simulating what compensated hypercapnia is. It's where your kidneys have time to compensate for the acute increase in your PCO2. And what they found was that when these mice were exposed to Pseudomonas, that the mice died in the same manner between the patients who were only exposed post-infection and the mice that were exposed pre and post. So again, the acutely acidotic hypercapnic mice and the more compensated hypercapnic mice died at the same rates. And this was thought to be due to neutrophil function related to CO2 or neutrophil dysfunction. And so as we were about to publish our results, we also found this study in the Blue Journal that was looking at mobilization of carbon dioxide stores. So in order to understand this study, it's first important to understand the way that CO2 is stored in the body. And so there are various body CO2 stores, and we call them different compartments based on how quickly they go in and out of those compartments. So blood is considered a fast compartment where blood CO2 comes in very quickly. So if you hypoventilate, your blood CO2 can rise very quickly, but you also can get it out of the system very quickly. Whereas slow compartments like bone store CO2 as bicarbonate in the bone, and it takes a while for CO2 to get into the bone, but also takes a little bit of time to get out as well. And then there are these medium compartments as well. And so there's always this movement of CO2 in and out of various tissues based on how quickly they can diffuse in and out. And so what this study did was it actually was a pig study that looked at various strategies of ventilation and looked at what CO2 did during these experiments. And so what I really want to highlight is in this figure A here on the left of the screen, you see basically PCO2 levels during various experiments. So the green one at the bottom is where the pigs were hyperventilated throughout the entire experiment. And then all the pigs were hypoventilated during this last 60 minutes. So this is showing the last 60 minutes of the experiment. And so in the green were the pigs that were hyperventilated throughout the main experiment part. In the blue, we have the pigs that were hypoventilated for some period of time and then returned to normal ventilation. In the pink, you have pigs that were hypoventilated for some period of time and then underwent what they called extracorporeal CO2 removal, which is essentially respiratory dialysis. And in the red at the very top, the pigs were hypoventilated for the entire experiment, including this last 60 minutes. And so what you see is for all the curves at the bottom, you see PCO2 initially rise when the pigs are hypoventilated, but starts to level off. And that's a sense of essentially CO2 kind of diffusing into other compartments as well. But in the pigs that were hypoventilated throughout the entire experiment, they're starting off at a much higher PCO2. And as you can note, the PCO2 does not level off. And so that's a sign that body compartments are just a little bit more saturated. And so PCO2 climbs in the blood much more rapidly, which may predispose pigs or, possibly humans as well to just much more acute events due to more rapidly increasing PCO2 levels and the kidneys not having time to compensate. And so I like to use this analogy of compensated hypercapnia essentially being like getting closer and closer to the cliff. You may be on level ground, even at higher PCO2 levels, but you're much more at risk of acute decompensations as you get closer and closer to the edge of that cliff. And so, that's really the analogy that we tend to use. Another analogy to think about is if you're just filling a glass of water, if that water is just about to overflow, if there's any more water, it's just going to overflow. Whereas, if it's half full, you have a little bit more buffer in that period. So I think these were really mechanisms that showed me why PCO2 actually does matter. It could have an effect on host defenses. And again, you're getting closer and closer to the edge of that cliff. And so the big question is there anything to do about this? So non-invasive ventilation has been a potential treatment for hypercapnic respiratory failure. There's been the strongest indications for NIV in acute exacerbations of COPD and also cardiogenic pulmonary edema. But there are numerous investigations that have studied outpatient NIV for chronic hypercapnia secondary to COPD. And then there have been clinical trials with patients with COPD that showed a mortality benefit. But I think there's a little bit more limited data, again, in terms of the patients that we see who have multifactorial respiratory failure, whether it's COPD plus heart failure, COPD plus obesity, and then also medications that might cause decreased drive. In severe stable COPD, I think this is the data that a lot of us know a little bit better. There's this prospective multi-center randomized control trial of stable gold 4 COPD. So that's an FEV1 of less than 30%. And so what they looked at was hypercapnia plus a pH of greater than 7.35. But one of the things that I think is very important to note about this study is that in their study, they used their NIV to target a reduction in baseline PCO2 by 20% or less, or by 20% or less than 48 millimeters of mercury. So it wasn't just that people were started on NIV, but they actually did have a biomarker target. And patients were randomized to either standard of care or nocturnal non-invasive ventilation, and their outcome was 1-year mortality. And what they found was that the 1-year mortality was 12% in the intervention group and 33% in the control group, with a hazard ratio of 0.24. And this was statistically significant. So really one of the first studies to show that NIV and COPD had a mortality benefit. And again, I think one of the things that's not talked about as much is that their NIV was used to reduce their baseline PCO2. And this is just showing that in the study, they were actually able to achieve a reduction in their PCO2. And again, this is in kilopascals. We're used to using millimeters of mercury in the United States, but this is basically starting out around probably in the high 50s or low 60s for their baseline PCO2. And again, reducing it to probably about the high 40s in the intervention group. And so the big question is, okay, this study showed that you have to reduce CO2, but how do we practically do this, in the outpatient setting? This was part of a study where they were able to get arterial blood gases. But when we think about patient care, we have to think about what's feasible and practical. So when we think about measuring PCO2 in the outpatient setting, there are multiple different ways that we can think about doing this. Really, our gold standard is arterial blood gas. So this is our gold standard, but there are multiple limitations. One in particular is pain. Two is that it's operator dependent. So for any of you who have drawn an arterial blood gas, you know that it either takes, 2 seconds or might take multiple pokes depending on vasculature. And again, sometimes it feels very random in terms of who we can get it on and who we can't. One of the biggest barriers actually is access to a blood gas lab. So blood gas labs have to be certified. And so I know in the hospitals that I've worked in, our standard PFT labs didn't always have a blood gas lab as well. And so sometimes you have to actually send them to another place to get it. And then you really have to deal with all these other issues, including pain and patient discomfort. And then one of the things to remember as we talk about body stores of CO2 is that it only gives you one snapshot in time. And so if a patient were to be hyperventilating because they were nervous, you can actually reduce their PCO2 a little bit. And again, knowing that ABG data, that one snapshot in time, doesn't necessarily tell you the entire picture. I think venous blood gases are becoming a lot more kind of widely used, much to my own personal dismay. But you run into some of the same issues. It is a little bit easier than arterial blood gas, but you still have to have access to a blood gas lab. But I think the biggest problem when it comes to chronic respiratory failure is that there is a very large and wide confidence interval. And this can be up to plus or minus 20 millimeters of mercury. So if you're talking about making clinical decisions based on a test that is not that accurate, I really hope that we're moving away from using venous blood gases because even on a given patient, on various different days, your values can vary quite a bit. So what about end-tidal CO2? This is something that I think a lot of people ask about because it's something that can be done on an outpatient. So I think there are certain benefits. One is that you can have very quick measurements. The other is that you can use this continuously. So when we're monitoring patients for moderate sedation procedures like a colonoscopy or an EGD, you can monitor this in real time. And it's relatively cheap compared to some other mechanisms of measuring CO2. But some of the limitations for patients with chronic respiratory failure is that it is minute ventilation dependent. It is dependent on your dead space. So if you have quite a bit of dead space from intrinsic lung disease, the measurements that you're getting may not be very accurate. And then one of the biggest reasons why we don't use it in our program is that once you start having leak, whether it's through the mouth or if you have someone on non-invasive ventilation, if you have any sort of leak in the system, it's not going to be accurate as well. You can use it in line with an ET tube. So I have had patients as an outpatient who are trached, who are able to use it in line and get a general sense of what their CO2 is. But again, there are benefits, but also limitations. Transcutaneous CO2 is actually what we use in our program at Michigan and what we're using here at NYU as I begin my program. And so this is a Centec webinar, and the Centec machine is a machine that we've used probably for about the last decade at the University of Michigan. So there are, specific benefits, including minimal bias, and that's thought to be plus 0.1 millimeters of mercury. There's a much narrower 95% confidence interval compared to venous blood gas, and that's plus or minus 6 millimeters of mercury. The other benefit is that you can do continuous monitoring. So if patient is hypercapnic and we're wanting to monitor to see whether our non-invasive ventilation strategies are working, we can put them on the mask, put them on the ventilator, and see whether we're able to reduce CO2 in real time. Some of the limitations, some of the big ones are cost. So it is quite expensive, not just for the machine, but for the disposables that need to be reordered and maintained. There is some machine maintenance. So you have to change the sensors, canisters. And so you really do need someone who can be a champion for the maintenance of the machine to make sure that you're getting accurate measurements. For anyone who is using it for a long period of time, so on the inpatient time or on the inpatient setting, or sometimes we'll use the Centec machine for overnight tests in the home, There are the technical issues of loss of contact. So if the if the patient has oily skin or is sweating a little bit, you can lose contact with the machine and then you don't get accurate readings at that time. So there are technical issues with any kind of prolonged use. But we were really interested at the University of Michigan to see what lowering CO2 did for patient outcomes, because we knew that patients with high PCO2 had higher mortality from our previous study. But because we were measuring CO2 at every single visit, we really wanted to get a sense of what was happening to our patients in the clinic. You know, anecdotally, I had this at least hypothesis that if we lowered the CO2, we were able to decrease hospitalizations and improve survival. But we wanted to see if there was a signal towards that and whether our data really suggests that lowering CO2 is something that is a necessary part of NIV management to go along with the study in stable COPD. And so this was just published in Respiratory Care this past year that was really looking at 10 years of University of Michigan data. And so what we did was we did this retrospective review of patients who were referred to their University of Michigan assisted ventilation program with baseline hypercapnia. So this is anyone with a PCO2 of greater than 45 at first visit. So we recorded the trend in PCO2 at 6 to 12 months during a 6 to 12 month follow-up period, and actually extended the PCO2 values for a total of 2 years. And then we looked at 2-year mortality adjusted for diagnosis, baseline PCO2, BMI, age, race, and Charlson Comorbidity Index. And so this is the data that we found. So pretty strikingly, you can see that mortality improves if we were able to reduce the PCO2 to less than 50. So we basically divided the groups into this binary system of PCO2 of less than 50 and PCO2 of greater than 50 at certain time intervals. And, you know, in the data below the actual graph, you can see the number of patients in each category before and after, and whether we were able to maintain that over time. And so you can see that most of the patients, we were actually able to achieve PCO2s of less than 50 at different intervals of time. And this seemed to make a difference in terms of mortality. But we also knew that, you know, again, a patient starting out at 52, going down to 49 is very different than a patient who starts at 85 and goes down to 65. So we also wanted to see whether the percent decrease in PCO2 would make a difference in mortality. And this was what our data showed, that we actually divided the groups, the patients into various groups, those with no change or an increase in PCO2 for some reason, patients who had less than a 10% decrease in PCO2 from baseline, a 10 to 19.9% decrease, and then a greater than 20% decrease in PCO2 from baseline. And as you can see, the greater the reduction in PCO2 from their baseline, the improved survival. So these patients were going from having a survival of, you know, maybe about 60% at 2 years to about greater than 90% if we were able to reduce their PCO2 by greater than 20% from predicted. So we really wanted this to be data that showed that not only do we have to start non-invasive ventilation on patients with chronic hypercapnia, but we also want to monitor PCO2 as a biomarker and try to achieve the greatest reduction in PCO2 from their baseline. And this chart just looks at essentially dividing the patient population into various different groups, including primary diagnosis, where they were started on non-invasive ventilation, were they on non-invasive ventilation before, and then also looking at their baseline PCO2 data. So I think what I really wanted to highlight was that, you know, over time, not only were we able to improve survival, but even for the most severe hypercapnia, for those patients with baseline PCO2s of greater than 70, for many of these patients, we were actually able to achieve a very large PCO2 reduction. And so as you can see in this last column, that most of these patients, no matter what group we kind of divided it into, was able to achieve a reduction in their PCO2 from baseline, with many of them being essentially either near normal or normal. So one of the final things that I really wanted to highlight as we talk about CO2 isn't just that CO2 improves outcomes in these patients, but also there are other uses for transcutaneous CO2 monitoring in the outpatient setting. So I mentioned that in our clinic at the University of Michigan, we got transcutaneous monitoring on every single patient at every single visit. And that way we're able to see whether or not our ventilation strategies were working over time. But I think one of the things that I've learned from the patient population that I see is that it can also be used in terms of understanding who's most at risk. So at the University of Michigan, I was working within their ALS Center of Excellence. And, we would get the transcutaneous monitor on every patient that I saw in the ALS clinic. And we use this as a decision tree to determine whether or not we would admit patients to the hospital for initiation of NIV. And so particularly during COVID, as patients were coming in much sicker because they were delaying some of their medical care, I started to see some of these patients that I was admitting directly to the hospital for initiation of NIV. So it's important to note that in the United States, a majority of NIV initiation happens in the context of the home with a DME company. Yet, and this is very different from practices in other parts of the world where patients may actually be hospitalized or titrations may be done in the sleep labs. In the United States, most of these patients are just being titrated in the context of the home. But as I started to admit some of these patients, what we wanted to do was actually look back and see what were these patients like and what happened during their hospitalizations. So we published this study. It was just a small case series of patients specifically with ALS, who I admitted based on their transcutaneous CO2 levels in clinic. And so this was a series of 8 patients, various ages, a mix of male and female, various BMIs. But I think one of the things that I wanted to first highlight is what was their transcutaneous CO2 level in clinic. So there was one patient who had just a mildly elevated PCO2 level of 48, and I think that was more related to just logistics of trying to get her non-invasive. She lived out of state, so it would have been a little bit trickier. But you can see that most of these patients had actually a relatively high PCO2, from 48 up to 64. So many of us who work on the inpatient side actually might see 56 or 52 and say, oh, that's not that bad. But I think it's important to understand the context of why this is high. So remember that for any patient with ALS, this is a rapidly progressive neuromuscular condition where they physically do not have the muscle strength to be able to maintain minute ventilation to either maintain their PCO2 at normal or to hyperventilate to try to bring it back down. And so these patients are already falling off the cliff. And so we're really trying to get them back to normal as much as we can. So it's important to understand, again, like what is their disease process and how at risk do we think that they are. And you can see based on their spirometry and muscle forces, some of them had really reduced FVC, but some of them actually looked okay. So an FVC of 66% predicted actually isn't even one of the criteria for Medicare for non-invasive ventilation in neuromuscular disease. So that's where transcutaneous CO2 becomes so important as another piece of data to help you understand how sick these patients are. And then this data actually shows what happened to these patients during their hospitalization. So they got blood gases once they got admitted to the hospital, and then you can see that some of their PCO2s were way higher than they were in clinic, which just, again, shows you how close they were to being near the edge of the cliff. One of them even got up to 84 with a normal pH. And then upon discharge, we were able to lower their PCO2 quite a bit, either by venous or arterial blood gas. So we didn't normalize everyone, but obviously they were on the trend towards improvement. And then on follow-up, I think there are a couple things to note. One is that the transcutaneous CO2 in most of these patients was essentially either normal or very near normal. And most of them had improvements from their hospital discharge. But then the other key is that the amount of non-invasive ventilation that they needed to use in order to maintain that normal or near normal PCO2 was oftentimes greater than 20 hours, sometimes continuous, but at least half the day for most of these patients. And that's why a lot of times we talk about what does it mean to be adherent to non-invasive ventilation therapy. And we use this arbitrary value of 4 hours based on sleep apnea data. But I think what this study showed was really that for some patients, it may be 24/7 non-invasive ventilation to maintain normal capnia. For some, it might be just nocturnal. But really rethinking how we're thinking about non-invasive ventilation strategies, that it can't just be about a random adherence criteria of hours of use, but we have to think about hours of use in the setting of maintaining a PCO2 that is as close to normal as possible. And so in summary, I really wanted to highlight during this talk that chronic elevation of blood CO2 is a condition with very high mortality, that transcutaneous CO2 is an effective method to monitor PCO2 in the ambulatory setting, and really to highlight at least that hopefully people will get a better appreciation that PCO2 needs to be measured, whether it's through transcutaneous or through arterial blood gases, and that NIV management of patients with hypercapnia should be targeted at the highest reduction in PCO2 from their baseline. And so no matter how you're monitoring PCO2, whether it's through transcutaneous, arterial blood gas, venous blood gas, or end-tidal CO2, or using a surrogate like bicarbonate, that, the method that you're using is going to be dependent on what resources you have. But hopefully people have at least an understanding that there should be some attention paid to reducing total body stores of CO2 when you're using non-invasive ventilation management for patients with chronic hypercapnia. And so with that, this is my information in case anyone has any questions in the future. But for now, I think we have plenty of time for any kind of question and answer. So I will, let's see.
Yes, we do.
Okay.
Thank you, Dr. Choi. Let me go ahead. So before we get to the questions, and again, make sure if you do have a question, you are putting that in the Q&A. First off, thank you, Dr. Choi, for that awesome presentation. A lot of great information, some really great takeaways. We do have some questions that I want to get to, but if you missed it at the top, I do just want to remind everyone joining us that this course is accredited for 1 contact hour by the AARC, the California Board of Nursing, and the AAST. So just remember that at the end of this webinar, you will receive a automatic kind of pop-up with the evaluation form. If you miss that this time around, it will be in your follow-up email. Just make sure that you complete that evaluation, include your AARC number or nurse license number if you have one, and you will get that certificate. So with that, I would like to move into the questions, and I'll actually stop sharing so that you're able to see us a little bit better. But so we have quite a few questions, so hopefully we can get to most of them. The first question here is, we frequently have patients with their serum bicarbs over 40 to 45, and they're wondering that if you do see patients like this, do you give diuretics or others to like Diamox or others to stimulate more ventilation, or what's your normal care protocol with those patients?
Yeah, so generally not Diamox unless it's in the inpatient setting, and essentially we're just trying to reduce CO2 while we're using other strategies. We certainly, it's not a chronic long-term therapy in terms of trying to improve alveolar ventilation over time, but there are times when we will use it on the inpatient side to try to reset their baseline a little bit. Certainly diuretics like Lasix will worsen the problem as you're contracting the patient quite a bit. These are really patients who are getting like very aggressive IV diuretics, and those are patients that you really want to pay attention to, because I think a lot of times you see their serum bicarb go up, but no one's really paying attention to what their PCO2 is doing. So it really, if they have underlying respiratory issues, I think aggressive diuresis can really worsen the problem acutely. And so those are just patients that you want to pay attention to, start non-invasive ventilation early. But But again, Diamox I will use for a few days to just try to reset their baseline a little bit as we're trying to augment their ventilation with non-invasive ventilation.
Okay, great. So there's a few questions out there about your NIV use and kind of, yeah, anything from starting NIV to the settings. Maybe the first one here is, how can we strike a balance between acclimatizing patients to NIV? So like if we need to start with suboptimal NIV pressures and the goal of ultimately reducing CO2.
Yeah, that's a really great question. And I think that's where it's really important to understand risk and risk of the patient. So if their PCO2 is 55, chances are they're not going to become so acutely acidotic. Their body stores still have some room to basically absorb some of the blood CO2. And that's where, and this is what happens a lot of times on the outpatient side, where they may not be able to tolerate very high pressures that give them a lot of minute ventilation. And so it's really gradual increases in, that inspiratory pressure. But if their PCO2 is 85, and they're getting a little bit lethargic, you don't really have that time because the next step is going to be intubating them. And so if for some reason, this happens on the inpatient side all the time, where some of our practitioners may not really understand the risk as much because they're kind of, the patients are kind of walkie-talkie. But they're walkie-talkie until they're not, until they're obtunded and then they get intubated. So I think that's, I think there are a couple of things. One is that, we're really trying to educate the pulmonary community to say, no, this is a bad thing and you have to reverse it because of all the explanations that I talked about in this talk. And then counseling the patient to say, hey, we want to do everything possible to not put you on a ventilator with an endotracheal tube, because then they'll be sedated, then they have other risks associated, because that really is the next step. So counseling patients to say, I know you don't love this, but the only way to get you healthier is to use this mask. Otherwise, you're going to end up on a ventilator. So it's kind of this balance of knowing kind of what do you think their current risk is and then adjusting your therapies to that.
Yeah, absolutely. And that's interesting. I mean, you bring up kind of coaching the patient and also coaching some of your other providers. I think we can all, when you say, yes, high CO2 is bad, this is going to lead to an increased risk of mortality, and we need to reduce it. Do you think that this is, I don't want to say like a novel concept, but do you think that people are like, oh, yeah, that makes sense. You're inpatient clinicians, things like that. Or do you think there's still a paradigm shift that needs to happen?
I think it's, I've talked to a lot of people around the country, and I think there's like a very small camp that's like, yeah, this is, clear. Like, of course this is bad, but that's actually like more of a minority of people. I think people are starting to get the understanding that maybe it is bad, particularly as I've given more talks and talked to more people. But, a lot of times there's a delay between information that's published and actual implementation. It's this idea of implementation science. Like, why is there this delay between, again, like that Conline study in 2014, it's now 10 years later. And yet people, even if they know the connection between NIV and COPD, there's pieces of the puzzle that they're missing. And that's that study actually reduced their PCO2. So I think for a majority of the world, well, I wouldn't say world actually, because I think in Europe, this is the way that they practice. And so I think in the United States, there's not this appreciation that CO2 itself is bad. And so, I think people just think it's a surrogate for disease severity, but I think it's modifiable. And that's why we're doing so much of the research trying to show mechanisms. It's not just association, that we want to see actually what are the mechanisms by which people die, not just mice or pigs. So I think there's a lot of room for future research to be able to understand why is it that, does CO2 affect your immune function? Is that why COPD patients end up going to the hospital? It's not just that they have bad disease, but that they actually can't fight viral infections or bacterial infections if their PCO2 is high. So I think there's a lot of room in the field. And I think over the next 10 years, hopefully we'll get more of a, group of physicians who are interested in studying this. But I don't think it's necessarily like, old news for people.
Sure. Yeah, absolutely. No, that definitely makes sense. Thanks for that insight. And so regarding your study, the patients who required long periods of daily NIV to maintain their normal levels, did the study weigh quality of life issues as well as one of the criteria?
No, this was just a retrospective study looking at the chart. So we were basically just looking at, you know, CO2 levels essentially. But, it is something that I have to counsel patients with. So a lot of my ALS patients actually prefer being on non-invasive 24/7 because they can breathe better and otherwise feel like they're breathing normally. For other
Of course.
patients, I've, said in order to reduce your CO2, you're going to have to, use this more than the 12 hours that you're using it now. And that does impact their quality of life a lot of times because they're otherwise ambulatory. And so all I can, do is counsel them to say, okay, that's okay. Like, I'm not going to force you to do this. We really want to maximize quality of life. But just know that there's no other way to reduce your CO2. And so, you would probably live less time than if your CO2 was reduced. And those are part of just, shared decision making with a patient to weigh kind of quality of life with length of life. So
Yeah,
if we have
absolutely.
something like respiratory dialysis, unfortunately, like non-invasive ventilation is the only way to do that. And not everyone wants to be on a machine 24/7.
Yep. And so there's a question out there about any suggestions on improving patient compliance with NIV when they are in the home.
Yeah, so I think that that's a complicated thing because, what I've learned over the last 8 years of doing this is that compliance is, not all NIV is the same. You really have to have a skilled practitioner, skilled respiratory therapist to understand. I didn't get into things like modes and the ways that you actually get someone more, kind of accustomed to the NIV, but there's a lot that you can do, including meeting their demands. So I always use the analogy of going to an optometrist. You don't just get glasses, right? You go to the eye doctor and they make, however many different adjustments, and you don't even know, you can't necessarily describe in words why A is better than B or B is better than C, but you just have a gut instinct of what feels better or what looks, what you can see more clearly with. And that's the type of fine adjustment that I use when I'm seeing patients in my clinic, is that I'm trying to optimize how they're feeling. So, obviously there are things like mask fit that don't take a lot of, kind of skill or expertise. But when it comes to actual NIV adjustments and management and making sure that they're comfortable, this is why I think people, like get the best care at specialized centers, that not everyone is trained to be able to do this, including, all of my colleagues at Michigan. We had a specialized center, so they really relied on our team to be able to make all those adjustments. Otherwise, if you don't know exactly how to make someone more comfortable, all they say is, I don't like this. And then you say they're non-compliant rather than actually being able to make the adjustments. It's like trying to send, someone to an ear, nose, throat doctor for eyeglasses. They're different fields, they're specialized fields. Just because they're both on the face doesn't mean that everyone can do this. And so that's why we focus so much on education. That's why I give so many talks on really understanding specific modes of non-invasive ventilation, knowing, the ways that the ventilators work, because it's not just, this isn't a sleep apnea field. This is respiratory failure. This is outpatient ICU management. And I was trained for 3 years in pulmonary critical care. And I think there's this expectation that everyone just knows this, but we have to remember that this is a very new field in medicine, in pulmonary medicine. So, I talked to a lot of our respiratory therapists who are very, very good, but they're like, we didn't learn this in school. So you really have to kind of learn on the job and learn it from people who really know how to do this. And so I think the field is growing. I think for any respiratory therapists out there who, kind of are thinking about home care, I think there's a lot of exciting advances. But yeah, adherence is one of those things that is so challenging. And that's why studies are limited, right? Because, all it's doing is just saying like, some of the stats out there are that, like for, sleep apnea, less than 50% of people are compliant. But, again, like this is respiratory failure. This is life or death, sometimes in a very short time. So again, like we want to be at a specialized center where people know how to manage this and they're doing everything possible to make someone comfortable. And then, some people are intolerant. I just think that and I think our data shows this actually for most of our patients, we were able to reduce their CO2, which means that we were able to get them compliant. So yeah, just a lot of learning.
Yeah, absolutely. Absolutely. So there's another question from, I believe maybe a inpatient bedside RT. So how can the bedside RT assist these patients for the discharge to homes? Should they as RTs be pushing the doctors to order an ABG with and without NIV to help them qualify? Do you have any thoughts on that?
So qualification is a tough thing. That's where you kind of have to know the insurance issues, which is, really like a separate talk in and of itself. And so, understanding who needs, an ABG, who needs, very few people need a sleep study for chronic respiratory failure. That's one thing. But I think understanding what machines are out there, how do you qualify for different types of machines? Again, this is an entire separate talk. I ran an event conference out of the University of Michigan that we held in Philadelphia last week. And so again, this is a 30-minute talk in and of itself. So, but I think the best thing that a bedside RT can do is to alert the clinicians and say, hey, this ABG is bad. This patient should be on non-invasive as an outpatient. Can we start the process? Because I think there could potentially be a knowledge gap from the physician standpoint. They may not know. So you can say like, oh, I went to this doc, from this specialist, and I think this person would be, a good candidate. And then, starting to reach out to the right resources to know, like, how do you document? How do you actually get the patient qualified? Again, too much for, the last 3 minutes, but.
Of course, I know the questions are always big for the last 3 minutes. I know the pain. I guess maybe another one that's in, so you mentioned at the end of your talk that hours of use is not really a great way to frame how we should be prescribing NIV or, administering NIV in the outpatient setting. But are there any specific starting settings or targets that you do typically begin with, or is it really patient condition dependent?
Yeah, I think it's patient condition dependent. If someone's, I deal with a lot of stable, like neuromuscular disease, like early on in their disease. So a lot of times we will start with pretty low settings to begin with and work our way up over time. But the biggest thing that I would say, if I were to change the field as a whole, change kind of the way that we think about it, would be to say, our goals for non-invasive ventilation are to optimize settings and hours of use to maintain normal capnia. That's kind of like how I would phrase it in a very simple way. So if they're normal capnic and they're comfortable and they're using it, 6 hours a night, then that's good at that time. And then you continue to monitor CO2, continue to monitor data downloads over time, because most diseases change. ALS, one day could be drastically worse in 2 months. And so that's why, just having one ABG that looks normal is not helpful, when you have a disease that progresses over time. And so that's why we're big advocates for longitudinal monitoring of non-invasive ventilation and PCO2 over time. And, for us, Transcutaneous has been the most practical, accurate way to be able to do that. Again, if blood gases were simple, like if you could just do a finger prick, like, glucose monitoring, then yeah, it's going to be more accurate than something that's through the skin. But until technology changes, I think the limitations of other modes of monitoring CO2 are just too much. And so again, this is how we do it at Michigan. This is how I'm doing it at NYU. There are a bunch of other large vent programs like University of Pennsylvania that also use transcutaneous CO2 monitoring.
Well, great. I think that's a great note to end on. I think it's very clear that education is just so important in this field, and I'm glad that we were able to support you in spreading this message today. So to anyone that still has an open question, we will get back to you. We will respond to you. We just don't have time for all the great ones that were out there. But for now, Dr. Choi, I just want to really, really thank you for the time and effort you put into this and that you put into your patient care. And yeah, thank you for being with us today.
Thanks for the invitation.
Thank you.